Good morning, everyone, or good afternoon or good evening if you're joining us from another time zone other than the East Coast. So we're excited to be back with Arkana Live today. And my name is Samira Farouk. I'm a transplant nephrologist at Mount Sinai in New York City. And I'm going to hand it over to my co-moderator, Matt Sparks.
Hello, everyone. Thank you for the first Arkana Live in the new year. I'm Matt Sparks. I'm a nephrologist at Duke University. And Arkana Live is a live pathology session, and it's an opportunity to get in the microscope, talk to a pathologist, but also have nephrologists who are trying to understand pathology as well. And so this is really meant for learners, for experienced nephrologist, anyone who wants to get a deeper dive into
Hey,
pathology.
Dr. Sharma, you have to hit record.
I hit record.
Thanks.
So today we're going to intratubular casts, and we're going to have a pathologist from Arkana Labs, and it is Dr. Zeljko Dvanajscak, and Dr. Z is what we'll call him. He is actually a native of South Dakota, did his medical school at the University of Colorado, and then his general pathology residency at UC San Diego. Then did his nephropathology fellowship at Arkana Labs, and now he is on faculty. Some fun facts about Dr. Z. He is an avid motorcycle enthusiast, and I think he rides a Kawasaki. Maybe he can tell us more about that. And he's enjoying the weather in Arkansas. There is apparently a blizzard in South Dakota right now, so welcome. We also will be joined by Dr. Sri Sharma, who is one of the faculty members at Arkana and also one of the co-founders of the Arkana Live Pathology series. So here's how this will work. We want you guys to ask questions. We don't have the chat open just because it gets a little bit wild with everybody's chatting in the chat box. If you have questions, ask any of the hosts, myself, Dr. Farouk, Dr. Sharma, and we will answer them, or we will talk to Dr. Z about what that may be. Dr. Farouk also posted that all these sessions are recorded, and you can go to the YouTube channel to check those out. So let's go ahead and kick this off. Dr. Z, you want to share your screen?
Sure. Okay, can you see my screen okay?
I think they want a brief discussion about your motorcycle first.
Oh, sure. I have a Kawasaki Z650. It's a 650cc Roadster, and it's a really great bike, especially for Arkansas. Arkansas is an incredibly beautiful state with lots of windy roads, and it's really truly enjoyable. And it doesn't really snow a whole lot, at least not around Little Rock. So that's the story about the motorcycle. It's my favorite hobby. And thank you so much, Dr. Sparks, for the kind introduction. Yes, I've lived all over the country, and all over the world. I'm originally from Eastern Europe. I moved here from Croatia in 1996 with my family. And here I am at Arkana and couldn't be happier. So I wanted to give a special thanks to Dr. Sharma for a wonderful introduction on some basic tubular interstitial diseases. And he's handed the baton over to me. I would like to talk about, as an extension, about renal intratubular cast, and this is going to be a two-part series. First part is today, and we'll talk about some benign and pathologic casts. And then on February 13th, we're going to talk more about crystalline type casts and crystalline nephropathies. So I'd like to start off by showing you this picture. So there are many, many different types of casts, and the list is very long.
Dr. Z, would you mind going into slideshow mode?
I'm afraid that might separate my screen. That's because I have two monitors and it splits the screen, so that's why. Is this okay though, or is it?
Yeah, no, it's great.
Okay. So the list of intratubular casts is long. Some are benign and some are extremely pathologic, and differentiating to two can be a seriously arduous task. So for pathologists, a thorough understanding of cast morphology is very, very important, as specific treatment and prognostic implications weigh heavily. So here's what I would like to cover today, if possible. If not, we can continue the discussion in February. So I'd like to start with talking about the two most common types of casts that we see in biopsies, and they're both benign. First are hyaline casts, and second are uromodulin or TAM horsefall casts. And after that, we're going to cover 5 of the most common pathologic casts, starting off with light chain casts, follow that up with myoglobin and hemoglobin, red blood cell casts, neutrophil casts, and bile casts. And I will be toggling back and forth between my microscope and this PowerPoint because I'd like to show you some additional images, and I'd like to talk a little bit about the clinical pathologic characteristics of these casts. I will also like to refer you to this paper that we wrote not too long ago, about 7 months ago last year. It's basically most of the pictures that you'll see and most of the discussion you can find in this paper, and it's open access, so everybody has access to it if you have access to the internet. All right, so we'll go over to the microscope. All right, I trust you can see that okay?
Yep, we can.
All right, so we'll start off about talking about the most common type of cast found in renal biopsies, and these are hyaline casts. And what's interesting about them is that they have a rather limited morphologic spectrum. They're round, pale pink, and homogeneous in appearance, as you can see here on the H&E stain. And they're actually often associated with thyroidization type of tubular atrophy, and it gets its name because thyroid follicles look just like this, actually. So these casts are commonly found. They're totally benign. They're lined by a simplified or thinned epithelium with not terribly reactive appearing nuclei. The nuclei are benign and somewhat compressed. And this is the H&E stain. Rarely, these casts are associated with a little bit of inflammation. Sometimes you can see some lymphocytes, some neutrophils within them. But overall, these casts have very much a limited morphologic spectrum, and this is their basic appearance. Now,
Dr. Z,
yes.
You know, we've had these things pop up from prior episodes of Arkana Live, and you know, some of those look a little scary. You know, they have like that broken glass look to it. How can you be sure that's not the case? Is that just an artifact of sort of the preparation of them when they have those little lines in it? Can you tell us more about that?
Yeah, sure. So these little lines that you see here, that's chatter artifact of a knife as it cuts through the slide. And I'll talk more about these casts and TAM horsefall casts and how you can differentiate chatter artifact from actual cracking. But yes, you're right, Dr. Sparks. These sometimes can be a little bit scary looking, especially on H&E stain. But on PAS, they're uniformly positive, and that's definitely a helpful feature. And the other thing is they're present in areas of fibrosis. They're not eliciting much of an inflammatory reaction. So the kidney's not really responding. Yeah, this is a good case. So this is they're associated.
I don't feel like that's good.
Well, so this case is actually a good classical case of APOL1 associated nephropathy and thyroidization type tubular atrophy with many of these hyaline casts as a classical pathologic feature. They're also associated with chronic obstruction and chronic pyelonephritis as well. So there are some clinical associations when you see this many of them. So I brought this case just because they're literally everywhere. But I think it's a good example of what they actually look like. And overall, these are completely benign. And
okay,
as we
so you're
go,
on H&E right there, right?
This is the PAS.
Oh, it's PAS. So okay, I see the edges. So that's why they're lighting up a little brighter.
Yes, so the PAS really pulls them out, and they're positive on PAS, but relatively uniform in appearance.
As opposed to like light chains and stuff? How do you distinguish the two?
Right. We'll get the light chains, and we'll talk about how to distinguish them, as they're definitely pathologic hallmarks. So light chains they're light on PAS. They're PAS negative most of the time. And we'll talk about additional features. So I just want you to sort of have an idea of what hyaline casts look like. And I want to just mention that it's surprisingly little is known about what they're composed of, but early compositional and ultrastructural studies have shown back from the late 70s and early 80s that their primary constituent protein in these hyaline casts, the most common cast type, is actually uromodulin. So I'd like to talk about what uromodulin looks like now. And there's definitely some overlap, as you can imagine, between hyaline casts and uromodulin casts. Sometimes they're really indistinguishable. Sometimes they're essentially the same thing. But uromodulin casts are the ones that can create quite a bit of a headache for pathologists simply because they have such a massive and broad morphologic spectrum, as you can appreciate here. So you have three.
Dr. Z, one thing we like to do on this is to bring it back to the basics. So what kind of stain that is. So Samira is she knows this stain better than anyone. So tell us why and how, what this is.
Sure. This is the PAS stain.
Or Samira, tell us how you like to tell people.
Sure. My nephrologist way is to look for the tubular outline, and so I can see here that there's a clear pink outline. These tubules look maybe a little bit atrophic since it's not as smooth and looks a little bit wrinkled. And then I guess now we have another clue that the hyaline cast is PAS positive, and so a few different things that tell us that this is likely a PAS stain.
The favorite slide, yeah, love that stain.
And you can see the outlines of the glomerular capillary loops as well. It's a really beautiful stain. So yes, well done, Dr. Farouk. So we have three tubules, and all three of them are filled with TAM horsefall protein. And the reason I'm showing you this particular slide here is because you can appreciate the morphologic differences here. So on the left here, we have a not particularly dense, more of a frothy or fluffy TAM horsefall uromodulin cast with somewhat indistinct, irregular borders. And then you have one here that on higher power, if you go in closely, has a bubbly appearance. Can you appreciate that? And then the one next to it also looks very, very bubbly.
Oh my gosh, I never noticed that before. Can you stop it right there? Zoom in, make it a little bit crisper, the image on that.
Let me try if I can do that. Let me just adjust my objective here.
Oh, it's got little bubbles in there.
Yeah, it's got little bubbles. That's a very helpful feature to help point that this is to point to the fact that these are uromodulin casts. The bubbles are thought to be some component of lipid present amongst the uromodulin here. But that's a very, very distinctive feature of uromodulin casts, PAS positive with lots and lots of bubbles. Okay? And now you can see that the one on the left is it's not very dense. It's very frothy in appearance. The one next to it is dense, and you see these regular parallel knife chatter lines, right? And then when you go over here, this one also has bubbles, but they're much bigger. There's some small ones here, but these are much bigger. And you can see that this one has very sharp edges, and it's very, very, very dense. So I'm showing you this because all three of these are uromodulin casts. Okay? And I would also like to show you another PAS of another case because I would like to demonstrate a couple of other features. And these are features that sometimes can scare pathologists, in particular novices. Dr. Sparks talked about fracture versus knife chatter artifact. Yes, as it should. But you have a strongly PAS positive cast with bubbles in it, right? And then here's a big fracture line. So that, on appearance, on PAS, to me, this is just a broken TAM horsefall cast, and they do have this appearance occasionally because they can be super, super dense, and the density is dictated basically by the salt concentration in the tubule. So I just wanted to point that out, and then here's a case where you have many, many of these dense casts with sharp lines around them. On PAS stain, they're a bit more pale and a little bit scarier. So we really do rely on the strong PAS positivity and the bubbly or frothy nature of them. See how scary they look here?
So the moral of the story for this is say, all right, put that on PAS. If it lights up bright and then you really zoom in to look for bubbles, then this is probably a benign hyaline cast.
Correct. And thanks
And
for
it's made of
saying that.
uromodulin too.
Right. So the difference between hyaline and uromodulin is not that important. Sometimes they're really the same thing. Like here is, because the primary constituent of hyaline cast is uromodulin. So they're sort of on a spectrum. And then sometimes even uromodulin can have a little bit of inflammation within it. If you look around here, this inflammation is inflammation that you see within areas of fibrosis. So this isn't actually a reaction to the cast. And I would like to show you a couple more images on my PowerPoint here.
And just to bring that home again, so a hyaline cast and a uromodulin cast are the same thing, or are they different? Or can you call it all hyaline cast, or be more specific and call it uromodulin if you see the bubbles?
Yeah, you can be more specific. Usually hyaline casts are sort of the uniformly rounded structures with a limited morphologic spectrum. They sort of aggregate in clusters. And when you see that, those are sort of typically hyaline casts, or as we call them. Sometimes they can appear totally independent in the kidney apart from anything else, and the very monotonous rounded look to them points to the hyaline nature of them. But when you see more of an irregular type of cast with this sort of this bubbly or frothy nature and strong PAS positivity, that points more to a true uromodulin cast. Does that make sense?
Yes, that makes sense. Thank you.
So just to review with this picture here, so panel D, you can appreciate the bubbly nature of it. Panel E, I want to show you this because the variation in color, you have to understand that sometimes the PAS, they can be PAS light, very pink, light pink, depending on the density of uromodulin. And other times they're very, very dense. Here you can see the chatter lines as well. Panel F here, I'm showing you a large fracture line here that you see commonly with dense uromodulin casts. And panel G, this is interesting. Sometimes they're so dense that they can protrude beyond the edge of the actual biopsy, beyond the limit of the tissue itself. So they protrude beyond it. This is actually a feature of light chain casts as well. But I just want to point out to you that TAM Horsfall can do things that are similar to light chain casts, but the way to differentiate them, of course, is strong PAS positivity, the bubbly nature, and if you're really not sure, you can use the uromodulin immunohistochemical stain, which is a very, very helpful tool. So I just want to show you how this stain is used. On the left here, you have PAS stain, and you have uromodulin. In this case, uromodulin has actually spilled out of the tubule and out into the interstitium. Sometimes this happens, and it can elicit a bit of an inflammatory reaction. If you see a lot of this, it could point to the possibility of obstruction in the kidney. Strongly PAS positive, and then you have a tubule with some intratubular TAM Horsfall protein. So when you stain for uromodulin IHC, the exact same field, you can see that the actual cast is positive for uromodulin. And what's nice is that the distal tubules of the kidney also light up. And the reason for that is because the distal tubules are where uromodulin is produced in the kidney. It's the only place it's produced in the body. So it's a really, really nice internal positive control. So if you're not entirely sure, if you're a little bit scared, you can always order this stain. And then, of course, we rely on the immunofluorescence to differentiate them from light chain casts as well. And I'll talk about that in a minute. But first, I'd like to give you a few fun factoids about uromodulin as a glycoprotein itself. It's 85 kilodaltons, and like I said, it's produced exclusively by these tubular epithelial cells of the thick ascending portion of the nephron. And intratubular salt concentrations are really what dictates how they aggregate and how they basically form this gel within the tubules. Uromodulin as a protein is the most abundant protein in the human urine. It's produced at a rate of 50 to 100 milligrams per day. So quite a bit of it is produced. And the primary function of uromodulin is to provide a cytoprotective effect to urothelial cells against infections. And as a matter of fact, uromodulin binds fimbriated E. coli and prevents their adhesion to the uroplakin receptor that's present on the urothelial cell surface. And this antimicrobial function is its primary cytoprotective effect, and it's certainly not limited to E. coli. It's been experimentally proven to prevent infection by Klebsiella staph and Proteus species and many others. Also, it's very, very important, uromodulin is very important for the prevention of nephrolithiasis. And if you knock out uromodulin gene in rodents, you can see a huge increase in calcium crystals and increased aggregation of calcium oxalate and calcium phosphate, which leads to stone formation. And of course, uromodulin has many other functions: Wnt signaling, cell polarity, cell cycle regulation, etc. So it's a very common cast type to see, and it's very important to understand this morphologic spectrum that I just showed to you. Okay, any other questions on uromodulin?
One thing I wanted to point out is I had mentioned I was scared about fractures, and the reason why is because the scary part of it is myeloma cast nephropathy, and those are really bad things. And so that's why for a novice like you called me, when I see those, I get scared. But now I'm learning about how to distinguish them. So that's why. I also shared a really cool post on Uromodulin from Renal Fellow Network if you want to check that out. So what's the significance of the Uromodulin cast and why you want to stain for it? Is that just to again show have further characterization of it, or what's the pathologic significance of it?
Yeah, it's just to prove that they are indeed uromodulin and not light chain casts.
So again, you don't want to have the scary light chain casts.
Exactly, and I'll show you in a minute what uromodulin stain looks like in light chain casts and how you can differentiate the two. And I'm glad you talked about how scary the fracturing is and the appearance on light microscopy. And I've switched over back to my microscope, and here's light chain casts.
Again,
you see that?
We're in PAS. Look at,
correct.
If you can look around, you can see the basement membranes around the tubules light up. You don't really see, maybe a little bit of a glom fell off on the upper left-hand side. And then as opposed to the other one, these are light. Yeah. But to me, they still look the same kind of fracture, but maybe I'm just a complete novice.
No, you're exactly right. It's the same exact kind of fracture. You see these parallel lines, so that's knife chatter artifact. But then here you see a large chunk of it just fractured off, and then down here you have a fracture line going all the way through. But what's interesting about these casts is notice how glassy they are. It's really hard to find bubbles in here.
Can you go back into it and try to get it a little bit more sharp on focus? It's hard. Sure. It's hard to see.
Sometimes on these high power images, this is the best we can do. We're at 40x here. Let's go even higher. Okay, so see how glassy they are and how pale they are? Can you appreciate that? And how few, if any, bubbles are identified and how sharp the edges are.
How about how closely it's abutting the parietal epithelium? Or not parietal, I'm sorry, in the... how far is it abutting the tubular epithelium? Is that
right? It's basically packed in there. It's dilating the tubule, actually. They're so dense and there's so much light chain material that they're dilating the tubules.
Got it.
And you can see that throughout. And
so the tubules are actually kind of like wimpy looking, really small and not as big as in the other one. Do you think you can go back to looking at a Hyaline cast real quick so we can remind ourselves?
Yeah, sure. So this is PAS of light chain cast.
I'm going to overrule Matt. Can you actually stay here? It looks like there's a layer of cells around the cast. Is that part of the reaction?
Right. So thank you, Dr. Farouk. So what you see down here, and this is a hint, and I'll show you another cast, is this possibly a giant cell reaction? Right? You see, you have a cell here, possibly just packed full of nuclei. In this one, it's hard to tell, but let me show you one just downstream. Do you see that right here? This is a giant cell that's trying to gobble up this huge light chain cast. Okay, so that's a very, very good point.
It kind of like spreads out, so there's cells like all around it, because it looks like there's like a one cell layer thickness that goes all the way around.
That's a tubule. It's pushed out, right?
It's either the tubule versus the actual cytoplasm of the giant cell trying to wrap itself
can you
around.
go back to the other one that's a little bit higher
Yeah.
up? That one was a little bit clearer. You could see that it was not touching the tubule, and it still had that one cell layer. A little bit higher up, the really big one.
Yeah,
To the
right here.
No, the other one. Yeah, this one.
This one. Mm-hmm.
Oh,
So you can see, I think this is possibly the tubular epithelium that's stuck to it and sort of ripped off from the basement membrane here. Okay, so but there is some inflammation. Here's a neutrophil, right? So there's a little bit of an inflammatory reaction to it, and I'll show you some more images of this as well. And then here, it's hard to tell if it's a giant cell reaction versus the sloughed epithelium. It's sort of ripping off the epithelium off the basement membrane up here. But yeah, very, very good point. And notice, if I zoom out, this is a very inflamed kidney. There's so much inflammation here. And then down here, I want to point out something very interesting. So you have a little piece that's broken off right here, and it's very, very PS pale. And then down here, you have a light chain cast with a few bubbles in it. Can you see that? So why does the light chain cast have uromodulin type of bubbles in it? Most of them don't. This one doesn't. It's very, very glassy, but then this one does. So the reason for that is because uromodulin is actually necessary. Its presence is necessary for light chain cast formation. Why is that? Not entirely sure, but in rodent animal models, if you actually block the complementarity determining region of the light chain, that prevents binding to uromodulin protein in rodent models, you completely stop formation of light chain cast and kidney injury. Okay, so TAM horsefall is actually very, very important, and its presence is important for these light chain casts to form. So you can imagine that you can see these casts admixed with TAM horsefall in the same tubule, and that requires very, very careful observation of these casts on high power. And I'll show you a very scary case, a couple cases from now, where that's the issue. And then here, I think right here is TAM horsefall protein admixed with it. And Dr. Sparks and Dr. Farouk pointed out that, yes, there's typically a strong inflammatory reaction around them. You can see all the inflammation around this light chain cast, and then some inflammation here, and then basically throughout the kidney. Now, sometimes you can get even lots of neutrophils filling these tubules as part of the reaction process, lymphocytes, lots of reaction, very inflamed kidneys and light chain casts. Now, that's a very, very helpful feature when present. This inflammation, these giant cells, they're reacting to the abnormal casts. Your eye is drawn to the inflammation and to these pale casts. But I want to show you a case where you don't see a lot of inflammation, and I'll talk about why that is. And this is sort of a warning to you pathologists out there. Bear with me so we have another case where you have light chain casts right here. And see how some of them are round and small. They almost look like hyaline casts, but hyaline casts are PAS positive. These are totally PAS pale, and this is also PAS stain, okay? And there's no inflammatory reaction around them, or very, very little in this case. Here, this one is just sort of hanging out by itself. There's not a whole lot of reaction to it. And what happened in this particular case is that the bone marrow was so wiped out, and there were so many plasma cells in the bone marrow that the patient was profoundly pancytopenic and couldn't even mount an inflammatory response to these casts. So I just want to point that out, that that's sometimes possible. So the finding of inflammation is not sensitive nor specific for light chain casts. It's really their appearance. So you have to train yourself to recognize them on PAS with or without inflammation to help you.
If you look at that cast there, the tubules look like they're not very healthy on that one.
So the light chain. Light chains
kind of oblique looking one. Yeah, that one. Yeah,
so they do injure the tubules, so you expect to see that.
So that sounds like a take-home message for this. Don't be fooled by just the cast. Look at what's happening with the cast around the tubules. Look at the inflammation. And then PAS staining is very helpful.
Yes, going close, lack of bubbles, that's scary, okay? And I want to quickly bring back the Hyaline cast from the beginning. See the difference? These are PAS positive. And the epithelium is also simplified here. So this is why there's a bit of overlap. So you have to be very careful with these types of casts to not overcall them or undercall them, okay? And then here they are throughout. I would like to show you a few more pictures. So quick review. Here's a nice picture of a giant cell reaction. So this is a Langerhans type giant cell. Here's a fracture line. Notice how it's PAS pale. Okay, so this is a classical look, classical appearance for light chain cast nephropathy. On the right is an H&E stain. And here you have Tam Horsfall, debris, lots of inflammation admixed with little glassy casts. And these are light chain casts. And notice the inflammatory reaction that they're inciting. Okay, and that's also a classical feature. And of course, the diagnosis relies not only on their appearance by light microscopy, but also you want to see restriction on immunofluorescence. And 2/3 of these casts will be kappa restricted. And here's a lambda of the. So what you want to do is you want to find the same cast on both kappa and lambda, and then compare them. And usually one is very, very, very bright. Okay. Now, if you're still not 100% sure, and you want to use the Uromodulin stain, here's what it looks like. So here you have a PAS pale stain on the left. It's protruding beyond the edge of the biopsy limit. You see that? And when you use the Uromodulin stain, what's nice is you have an internal positive control, which is this distal tubular epithelium, but the cast itself is completely negative. Can you appreciate that? So this is another helpful feature, and I would expect in this cast did restrict for kappa as well. So you have all of these tools. You have PAS, you have their morphologic appearance, and you have the Uromodulin stain, and you have the restriction on immunofluorescence to really help point to light chain casts. And this is a very, very, very important distinction to make because I'd like to talk a little bit more about light chains and their clinical significance. So a typical or a normal lymphoid system in the human will produce about 500 milligrams of free light chains daily that circulate in the serum. So most of this so they freely filter through the glomerulus, and once they enter the proximal tubules, they're reabsorbed by the megalincubulin receptor system. And this receptor system is so efficient in reabsorbing light chains in the tubules that only out of 500 milligrams that are produced per day, only 3 to 4 milligrams end up in the urine, or less than 1%, 0.8%. That's how efficient the proximal tubular epithelium is in reabsorbing a normal amount of free light chains. However, if you have a plasma cell dyscrasia like multiple myeloma, you can produce hundreds to thousands-fold higher circulating levels of monoclonal free light chains. And this can quickly exceed the resorption capacity of the tubular epithelium to basically reabsorb all the free light chains. And this free light chain, once it interacts with uromodulin in the tubules, will start to crystallize, like I said. So additional factors certainly influence formation of light chain casts. That includes ionic composition of the tubule fluid, the tubule fluid flow rates, as well as the presence of furosemide, interestingly. And patients with light chain cast nephropathy typically have multiple myeloma at the time of biopsy and are therefore usually middle-aged to older folks. There's one case series of 190 patients who have multiple myeloma who underwent renal biopsy at Mayo. What they found was that out of those 190 patients with multiple myeloma, light chain cast nephropathy is the most common paraprotein-associated lesion. It's seen in 33%, or about a third of patients. The mean serum creatinine at presentation is about 5.5, and all have variable proteinuria that ranges from less than 1 gram in about 10% to greater than 3 grams in about a third or more. And like I said, most of these are kappa type. And what's terrible about this disease is its prognosis. So the kidney survival in these cases from the time of biopsy the mean kidney survival is only 20 months. And the mean patient survival from multiple myeloma diagnosis once they have light chain cast nephropathy is only 44 months. So this is why it's incredibly important to understand the difference between light chain cast and its primary mimicker, the uromodulin cast. And this is why I wanted to show you this, because one is completely benign, the other one carries an extremely, extremely poor prognosis. So for those of you pathologists out there, use all of your tools. Study these casts well, and whenever there's a question, employ all the tools necessary to make the distinction, because the outcomes are so drastically different. I would also like to mention a couple of rare instances where you have light chain cast appearance on light microscopy, but you have no restriction on immunofluorescence. So what does that mean? So that can mean a few things. One, the light chain itself is so abnormal and truncated that the antibody used in immunofluorescence doesn't attach to it. That's one option. The other option is that it's not a light chain cast. And I want to show you a couple of rare instances that this is super rare, but I just want you to be aware, because practicing pathologists out there run into this, and this creates a big headache for many people. There's a case report that came out from Mayo Clinic again, where they basically showed, here's a cast on PAS stain from this paper on the left, and it looks just like a light chain cast. Pale, glassy, maybe some fracture lines as well. But on immunofluorescence, it didn't restrict. So what they did was they pulled out these casts and studied them by mass spec, and they found that these casts are made up of two proteins called REG1 and CPA1. You can see that they're positive on immunohistochemistry. And it turns out this patient had a pancreatic mixed Asner neuroendocrine carcinoma producing these two proteins. And they're ending up in the tubules and aggregating and crystallizing to form something that looks just like a light chain cast.
Oh, my.
Right.
And what about TAM's horsefall?
What about TAM horsefall?
Was it negative on that?
Yeah, it was negative. It was negative. That's right. That's right.
Wow.
So it's just
how would you even know to do those two things?
Well, you wouldn't. This is extremely rare, but this is sort of in the back of your mind. You should remember that,
other things can clog the tubules.
Is a thing. Right, paraneoplastic things. Also, I want to point out another thing. Here are some more casts here on the left that look like light chain casts, but there's no restriction. Vancomycin can give you casts that don't restrict, don't stain positive for anything, but look like light chain casts. In this paper, they were able to use an immunohistochemical stain to demonstrate against anti-vancomycin immunohistochemical stain to show that that's what that is. So this is where the clinical history for us pathologists is very, very important. But again, I will say that this is super, super rare. These two entities are rare, and I just want you to be aware of them in case this is encountered in practice. But most of the time, they will certainly restrict like you see here.
The one thing I was wondering about the vancomycin one and the other one is it that, can a Hyaline cast get stained with medications or other things? And how do you know it's, it's not just a Hyaline cast that has a bunch of other stuff in it?
Right. It's impossible most of the time. Sometimes, and this is anecdotal, something we haven't published at Arkana, but we've noticed that vancomycin tends to give a bit of a lilac appearance, a very characteristic lilac appearance, especially on Jones stains. And that's really the only hint, and we don't really have a stain for it. This immunohistochemical stain is very difficult. I think this original one was discontinued. So it's even, we can't even stain for it. So that's why this is really, really tough. This is really, really, really tough if you don't have restriction on immunofluorescence. But like I said, most of the time you will, the vast majority of the time. I just wanted to point that out to you just as an aside, just as a possibility that exists out there. Okay? Not sure if that answers your question.
Yeah, that does. We haven't talked about it, but is EM helpful in these casts, or is that something you're going to talk about later?
So one thing they mentioned in these vancomycin casts, it's helpful only for these casts. The other ones don't really give you much of an ultrastructural hint. Is these have little, almost like they look like nanotubules. The vancomycin, they're like little aggregates of nanotubules on EM, and that's what they reported in this case. Although I've never really seen anybody use that. I'm not sure how reliable that is. But so EM is really not something that's used to differentiate these casts. Most of the time, they give you really no hint whatsoever. You just get electron-dense material. Yeah. Okay, so that's the difference between TAM horsefall protein and light chain casts and hyaline casts. So now we will continue to another cast type that's commonly encountered. And we will start off with a PAS stain. Okay. So here we have a PAS positive.
That's very positive.
Yeah. So
Look at those
this one is
basement membranes.
Yeah, the basement very bright on this PAS. But this cast is interesting. So you have on the periphery, you have some bubbly material, which is TAM horsefall protein. But on the inside, in the center of the cast, you have this granular PAS pale. It's almost refractile on appearance. Okay?
And I'm wanting to like read these past slides now. I'm getting very excited.
I can send them all to you. Trust me, we have plenty of these. It's fun when you have multiple different cast types in the same specimen. And I'll show you an example of that a little bit later.
This is definitely not novice then.
Yeah, so you have to really understand what their morphologic, and this is what I'm trying to help you all understand how difficult this can really be.
There's cells in there.
Yeah, so there's cells floating in here. So these are sloughed epithelial cells off the tubular basement membrane. And then you have these casts that are forming, this cast here is forming these rope-like structures. Do you see that? Almost stringy, almost like a bundle of ropes here. Mm-hmm. They're kind of stringy. They're spaced out like that, basically almost filling the tubular lumen.
Almost looks like a glom that got destroyed, like the Death Star blew up or something.
Well, it looks like how you would see tubular epithelial cells in the urine.
Oh, yeah.
Yeah, you're absolutely right, 100%.
So just pretend like you're looking at a urine sediment that's stained with SM stain.
Right.
Looks cool.
Yes, it's an interesting look to this kind of cast. And then up here, once again, they're kind of granular, almost globular in some areas. PAS positive to pale intermediate, and focally they're forming almost like little beads. I think you can appreciate that within a tubule. So these are myoglobin casts. Let me show you the myoglobin immunohistochemistry. Here's the myoglobin immunohistochemistry, and they're very, very strongly positive. Okay, and then here, when you come in closer, you see these little ropes, these little beads forming and aggregating together. See that? Very, very, very bright on immunohistochemical stain. So the myoglobin stain has no internal positive control. There should be no myoglobin in the kidney. So when you do see it, especially within a cast associated with that morphology, this is myoglobin cast nephropathy. Okay.
It sounds like a good stain to use, because if you see something, it's going to really jump out at you.
It does, yeah.
Even from low
power, you can see them immediately. So it's not subtle. It really pulls out the stain strongly. This is one of my favorite stains to use because it is so specific. Okay. Now I want to show you another case, also PAS. Now, these are also interesting. They're a little bit more pale on PAS. Do you see them? These little granular, globular structures here, they're forming almost beads on a string type of look. Very similar to the prior cast type.
Almost look like red blood cells that have been like smashed or something.
Exactly. So sometimes they're confused as red blood cells, but these are not red blood cells.
So I'm making all the major mistakes then as a novice.
This is how you learn. We've all made these mistakes, and this takes a bit of training and staring at them to really get a good feel for them. They're smaller usually than red blood cell casts, but not always. So this, now let me show you another immunohistochemical stain. Also not subtle. This is hemoglobin. So these are hemoglobin casts. And if you look carefully, notice how dark they are, but if you look carefully, like we talked about on light microscopy, those aren't actually red cells. That's just a hemoglobin that's aggregated in the tubule. And if you look very, very closely, you can see, here's a glomerulus. You can see a few very faint positive cells. These are circulating red blood cells. So that's your internal control. And then the casts are much, much darker, much, much darker.
And the stain is like hemosiderin or what?
No, this is immunohistochemistry against hemoglobin.
Against hemoglobin.
Right. Just like I showed you myoglobin, this is the same thing except against hemoglobin. And you can see how much of it there is.
So less of a ropey appearance actually sometimes fills the entire lumen. Is that right?
So no. So I'm showing you these because they look actually very, very similar. And you cannot, I'm glad you said that, because you actually cannot differentiate them on light microscopy at all.
Okay.
Cannot. And the reason for that is because they are basically a very, very similar molecule, hemoglobin and myoglobin, very, very similar molecule. And they both create this morphology that I want to show you with this slide here. So on the left, you have an H&E stain. They look sort of pinkish. Red blood cells, as you can see in here, red blood cells are really, really bright red, whereas these are not quite the same color. They almost have like a rusty brick red appearance to them. Sometimes they're finely powdery, other times they're granular, other times they're globular, other times they can coalesce to form even larger globules. In some cases, you have the ropes, and then you have beads on a string, okay? And then here's a picture of beads on a string on the left, and then a bundle of ropes. And you cannot tell whether this is hemoglobin or myoglobin because they both form these similar types of morphologies. And
so you're going to have to bust out the IHC for that, the immunohistochemistry.
Right,
cool.
Exactly. So we actually tried to find a way to differentiate them on light microscopy. And I spent a lot of time trying to do this. We used all sorts of histologic parameters, morphologies, cast color on the various stains, how they aggregate, etc. And really nothing could definitively help us point either way. They're so similar in appearance, and they have such a wide spectrum of morphology that really the only way to nail down what they are is by using immunohistochemistry. And you can see that IHC is the only way to do it with the p-value difference here. And we published this last year with our hemolysis work.
Not only did you prove me wrong, you published it to show that I didn't know what I was talking about. I like that.
That's right. That's why they hired me at Arkana, Dr. Sparks.
Nice.
One other thing, I want to once again reiterate how this hemoglobin stain is really a nice stain and how it's used to differentiate the two casts. So you have a very granular cast here, really nondescript in appearance, just kind of powdery and granular. So if you stain it for hemoglobin, it lights up very nicely, this cast, but it's totally negative for myoglobin. So similar to light chain casts, you really want to find the same cast on both stains to prove that cast is a different cast type. And then for myoglobin, of course, there's no internal control, whereas hemoglobin has these little circulating red cells that you see here on the left. They also light up with the stain, so that's how you know that your stain worked very nicely. And then, of course, the hemoglobin cast itself is very, very dark, much darker than the red blood cells, because their content of hemoglobin is much higher than the red blood cell itself. It takes thousands of red blood cells to hemolyze to create this kind of appearance. Now, let's talk a little bit about their frequency in renal biopsies. So myoglobin casts occur in about 1 out of every 130 biopsies that we see, whereas hemoglobin cast nephropathy is seen in 1 out of 1,600 biopsies. So the difference is 12-fold. Myoglobin casts are 12 times more common than hemoglobin cast nephropathy. Nevertheless, we use both stains. whenever we see this type of morphology to differentiate. And the clinical picture to differentiate the two is very, very important. And the reason for that is because, of course, myoglobin casts are produced by rhabdomyolysis or necrosis of muscle cells. And this leads to intravascular release of myoglobin, which is then filtered through the glomerulus and ends up into tubules. And when the acidity of the proximal tubule is lower than in the serum, they start to precipitate out once they reach a critical concentration. So this was also published by Arkana, led by Dr. Liapis and by Dr. Silva. What they did was they took 214 cases, biopsies with myoglobin cast nephropathy and studied them. And here are the etiologies that are most commonly associated with the presence of myoglobin casts in biopsies. The most common cause was drugs, both illicit and medicinal, and statins are, of course, the major player here. Additionally, is there a question? No? Okay. So other etiologies, there's a whole list of some you would expect, like myopathies, for instance, or seizures. People that have seizures, you would expect some degree of rhabdo. But then other, etiologies are sort of very nonspecific. Some are, patients sometimes are just found down, obtunded, unconscious, etc. Sometimes it's associated with traffic injuries, oftentimes really no etiology other than severe dehydration. We oftentimes see this with infections, including joint infections. We can see it with transplantation. We can see it with HIV patients and sepsis, as well as chemo patients, pancreatitis, and of course, intense physical activity, soldiers that are training, marathon runners, etc. We can see it after surgery, of course. Wasp stings can cause it as well, and then multi-organ failure. One other thing I will mention, just as a clinical aside, oftentimes clinicians are surprised when we tell them, hey, I'm seeing myoglobin casts in here, and then they say, but the CPK level is normal. So we see that not infrequently. So I want to talk a little bit about the CPK and how it correlates to myoglobin casts. So CPK level in this study, the average or mean CPK level was about 16,500 with a maximum value of about 330,000. However, a small subset of patients had completely normal CPK levels. And the reason for that is because CPK tends to be delayed. Its rise tends to be delayed after muscle injury, sometimes by up to 12 hours. And these levels, serum levels of CPK, often decline fairly rapidly after the onset of kidney injury, whereas myoglobin casts can be present in the kidney both before and after these time periods. So there's a push in the literature to actually use free serum myoglobin instead of CPK to assess for rhabdo and how that may be associated with kidney injury. Okay, so that's a little bit about myoglobin casts. Hemoglobin casts, however, the etiology is totally different. So hemoglobin casts are formed whenever you have intravascular hemolysis of red blood cells. So we had a series, which is the largest series of hemoglobin casts that we published last year, hemolysis-associated hemoglobin cast nephropathy. We had 27 cases. There's also a case series from India published the year before us, and they had 20 cases. And when you combine them all together in this table here, I borrowed this from Dr. Larson. These are the etiologies that are most commonly associated with hemoglobin cast nephropathy. And the number one offending agent is rifampin, and this is an antibiotic that we see most commonly used with mycobacterial infections. And rifampin is really a bad boy drug when it comes to hemolysis. And a typical clinical picture is that a patient is placed on rifampin, they discontinue rifampin for whatever reason, and then they suddenly reinitiate rifampin. And upon reinitiation of the drug, they get massive hemolysis and quite severe AKI. Other etiologies associated with hemoglobin casts are autoimmune hemolytic anemia, disseminated intravascular coagulation, transfusion reactions, chronic diseases that cause chronic hemolysis, such as paroxysmal nocturnal hemoglobinuria, as well as other medications and toxins. We had one case where a patient tried to commit suicide with sodium nitrite, which is a meat-curing compound, but turns out it causes massive hemolysis. Also, procedural causes can also lead to this. For instance, we've had a few cases of TERP-associated hemolysis where the urologist uses basically distilled water to irrigate during the transurethral resection of the prostate procedure, and that causes severe hemolysis. And then, of course, as you would expect, hemoglobinopathies such as sickle cell disease. Another clinical aside about hemoglobin casts that we found in our series was that oftentimes these folks, their clinical parameters look just like thrombotic microangiopathy. So they'll have anemia in the majority, they'll have low haptoglobin, elevated LDH, thrombocytopenia, and really, really high serum creatinine values, usually about 8 on average. And in our series, we found that some clinicians actually preemptively used eculizumab in these patients while they were waiting for the kidney biopsy, expecting to see TMA, and they treated them for presumed atypical hemolytic uremic syndrome. And on biopsy, absolutely no evidence of TMA, but lots of hemoglobin casts. So this is just something for you to be aware. If a patient really does look like TMA and they have anemia, definitely a renal biopsy is necessary to differentiate between TMA and hemoglobin cast nephropathy. Okay. Now, the good news
that's some
is,
quick eculizumab use there.
Yeah, it's very scary for people because if you don't treat atypical hemolytic uremic syndrome, the death rate is over 90%. Wow. I think it's in 95. Yeah. So people are, you see this. It clinically looks just like completely indistinguishable from TMA. So they
take the biopsy, and then, which is why the biopsy is very important in these.
Right, exactly. Biopsy is absolutely critical in these to differentiate the two etiologies. The good news is that these folks, both for myoglobin and hemoglobin, if they're treated properly, if the hemolysis is stopped, if the etiology is identified, and if the rhabdo process is stopped, these folks tend to do really, really quite well. So here we have a chart. This is from our 2019 KI paper. You have serum creatinine values at the time of biopsy for hemoglobin cast nephropathy, and then you have serum creatinine values at the last follow-up, and our average follow-up was just over 2 years. And these green dots here are the 4 cases associated with rifampin, and they all gave us double-digit serum creatinine values. So serum creatinine tends to give the rifampin-induced hemolysis tends to give really the worst serum creatinine values. And the other ones range from about 3 all the way up to almost 17 milligrams per deciliter. But on follow-up, these folks for the vast majority, did super well. They all came back to baseline. Some required treatment with hemodialysis, temporary hemodialysis, and supportive care, pulling of the offending agents, etc. But over time, they recovered extremely well. And these red dots here are cases for which we did not have long follow-up. The average follow-up for these cases here was only about 2 months. And we suspect that 6 or 10 months later, these folks returned all the way down to their baseline renal function. So that's why this is important to differentiate from TMA. TMA, of course, has a much worse prognosis. Okay, so the obvious question then becomes, why use an expensive immunohistochemical stain when you can just use an iron stain? Of course, there's iron in hemoglobin, right? So why not just use a simple Prussian blue stain that's commonly used in renal in surgical pathology overall? Well, it turns out that the Prussian blue or any other similar type of iron stain will not stain the hemoglobin casts. And the reason for that is because Prussian blue only stains iron that is weakly bound to its partner, such as hemosiderin, or iron that is present in the tubular epithelium once the hemoglobin molecule starts to degrade. Okay, but the cast itself is totally negative, so you cannot really use Prussian blue. The Prussian blue positivity here is the dark blue. Here you have some in the interstitium, and then these dots are iron within the tubular epithelium. But the cast itself is really pretty much negative. So for those of you out there, and this came up at conferences a lot, why not just use iron stain? Well, this is why. It doesn't stain hemoglobin casts, okay? So that's just a warning. You have to rely on the immunohistochemistry. Additionally, hemoglobin and myoglobin casts can coalesce, like I've alluded to earlier, to form casts that look a lot like light chain casts. Do you see that here?
Oh no, that's not
right.
good.
Right. So that's a little scary. Here is in a neighboring tubule, they look sort of classically granular, but here they're coalescing to look like light chain casts.
And
you
again,
have
that's
another
PAS stained. You can see the basement membranes.
Yep.
It's kind of a
Yep.
pale color, glassy even. No fractures though on this
Right.
one.
No fractures. So that's
I
a
don't
little
see any
bit scary.
bubbles
So
either.
Right. Exactly. So it's a little bit scary. So is this, this turned out to be strongly hemoglobin positive. So that's, and no restriction on immunofluorescence. So this is just a warning that the differential diagnosis of myoglobin and hemoglobin casts also includes light chain casts.
So when you see something like that, that's going to open up to a lot of additional stains.
Yes. So additional workup is
light chain
necessary.
restriction,
Absolutely.
hemoglobin, myoglobin,
Exactly.
maybe even uromodulin.
Right. Exactly. So and conversely, light chain casts can give you a granular appearance that look just like myoglobin or hemoglobin.
Oh, please stop
So
doing
that's
this
also,
to us.
Yeah, I'm serious. This is why
We thought we had it. Now you've just ruined it. You ruined it.
I know. So here's a panel of 3 cast types. They're all different. One is myoglobin, one is hemoglobin, and one is light chain.
I just want to break out a bunch of IHC and be done with it. I'm not even going to guess.
That's exactly what you do. So turns out that you cannot tell them apart, and this is how they are: hemoglobin, myoglobin, and light chain. And the only way you can parse that apart is by a careful use of immunohistochemistry and immunofluorescence to demonstrate which cast type this is. But on light microscopy, you have hints, and these are only hints as to what they may be to help guide your potential workup. But they can all mimic each other, so you have to be very, very careful when you study these casts. Okay, and now I'd like to show you, if we have time, another rather scary case on the microscope. Okay, so here we have TAM horsefall protein, right? Very bubbly, sort of not terribly exciting. Here's some TAM horsefall that's spilled out of the lumen out into the interstitium, some inflammation around it.
Wow, looks like a glom.
Right.
Massive one.
And then here you have something granular.
Oh, man.
Are these beads? Are these ropes?
IHC's coming.
And then we go down. Here's another TAM horsefall.
Yep, I see the bubbles.
Okay.
Not fooling me.
Not fooling you, Dr. Sparks.
Yep.
And then we keep going. And then this one's a little bit glassier.
No.
But it's PAS positive.
And look around it, though. You don't have a lot.
Yeah.
Yeah, maybe. Yeah.
But hold on. Hold that thought. Now watch this.
Oh.
Okay, so what do we have here? We have a hexagon, organic chemistry days, and then we have this PAS pale material, sharp edges, and then right next to it is PAS positive bubbly material. And swimming inside of the PAS positive bubbly TAM horsefall are, you guessed it, light chain casts. You see that?
It's like when you're flying over and you see a bunch of farms and crops.
Right.
You got too much going on here.
So there's a lot going on here. And then right next door, you start seeing some ropes, right?
Yeah.
Some beads on a string. And down here, some more rope. This looks like a bundle of ropes. So this turns out that this stuff in here is light chain casts admixed with TAM horsefall protein. If you're not careful, it's easy to just drive over this, and just these are call them PS positive casts, no big deal. But
so you need some light chain restriction on this.
Yes, there was light
this
chain
one needs a
restriction
bone marrow, and this is a lot going on. Wow.
Right. So, but then look at. Let me show you. So this patient had myeloma. This patient was actually found down at home, obtunded, and really sick and really, really high serum creatinine. And guess what? There's also myoglobin casts in here. Okay, so this is an example of multiple cast types, admixed, some pathologic, some benign, all swimming around together in the same kidney. And
So
if you look very, very careful,
we got
rhabdo,
we got light chains.
Correct. So we have rhabdo and light chain cast nephropathy in the same case. Admixed,
Yeah, well,
totally benign.
Someone asked a question about TAMS, horsefall, and Uromodulin. Are they the same thing?
Same thing. Same
yeah,
exact
it's two names for the same thing.
Exactly. Yes. Okay. How are we on time? So about
well,
11:08.
we got 5 more minutes. We can do stuff.
We can do stuff. Okay. So let's do red blood cell casts. How about that? These are fun. Let me just see one thing real quick here. Make sure I'm in the right place with the, yes, okay. All right, so here's a case where you have lots and lots and lots of red blood cell casts. Okay, here's a low power image. This is H&E stain. And you can see them right away from high altitude that these are red cell casts because of their beautiful red color. And they're a little bit refractile. If you take off the condenser, you can see how refractile they are. That's because there are iron content. And then you go in closely, and what you see is how densely compacted they are. They're pushing the epithelium to the side. The epithelium around it is injured, and they're in there, and they're densely, densely compacted, okay? And this is a classical appearance of red blood cell casts. And these are formed typically by a primary glomerular problem, glomerulonephritis, ANCA-mediated disease, and the list goes on and on and on. Something that broke the glomerular filtration barrier and allowed red blood cells from the circulation to enter the tubules. And here they are. But of course, nothing is really that simple in pathology. So what happens over time is these red blood cell casts, once they linger in the kidney, they start to degenerate. And once they start to degenerate, they start to create problems for pathologists. And I'll show you why that is. So as they degenerate, so let's go back to the PowerPoint. Let's discuss their look as they start to sort of break down or degenerate once they sit in the tubule. So here's a fresh red blood cell cast, just like I showed you, nice and brightly red, lots of injured tubules around it. The red blood cell casts are very injurious to the tubular epithelium, but once they start to degenerate, they start to lose their red, so they start looking more pink. The red blood cells, you can see individual red blood cells in here. We call these red blood cell ghosts. All you see is their membrane, right? And as they degenerate, they start becoming granular, like you see down here. And then at more advanced stages of degeneration, you only have a couple little red blood cell ghosts left in a cast that looks very, very granular. So we've seen this be misdiagnosed, advanced red blood cell cast degeneration be misdiagnosed as hemoglobin cast nephropathy. Why? Because they stain positive for hemoglobin. But upon closer inspection, if you go in very, very closely and look at all of them, you can find red blood cell ghosts in almost all of them. So advancedly degenerated red blood cell casts can look just like hemoglobin casts, okay? And they stain, of course, the same. But you have to carefully differentiate them. So another nice way to find these ghosts that you wouldn't expect in hemoglobin cast nephropathy, because the etiology is totally different, is by using other stains. So on the left here is the trichrome stain, and trichrome nicely outlines the red cell ghosts. There's some blue material admixed. This is TAM horsefall versus tubular epithelial debris. On the right here is Jones silver stain, and you see nicely outlined red cell ghosts. Okay? And I want to show you this picture. I think this is a powerful picture because it demonstrates my point. So in the center, you have a primary glomerular necrotizing and crescentic glomerulonephritis caused by ANCA disease, spilling red blood cells into the tubules. On the right here, this is Jones silver stain, by the way. You can tell it's Jones because the tubular basement membranes and the glomerular basement membranes are black. Okay, but here on the right, you see very granular cast, but you can identify individual red cell ghosts. But then this cast on the left is a red cell cast at a late stage of degeneration, and it doesn't have any red cell ghosts. So if you just have this, or if you're not looking carefully at other tubules and throughout the biopsy, this would trigger you to order a hemoglobin and a myoglobin stain, and hemoglobin will come back positive, and it's easy to misdiagnose this. If you have a limited sample, you don't have enough glomeruli, you don't have a whole lot of tubules, and you didn't look around carefully for red cell ghosts, this is easy to misdiagnose as hemoglobin cast nephropathy. Okay? So this is what I wanted to highlight about red blood cell casts, and that their etiology of formation is totally different. Hemolysis-associated hemoglobin cast nephropathy is caused by intravascular breakdown of red blood cells at which point hemoglobin will go through the glomerulus to create these casts, whereas red blood cell casts are formed by a primary glomerular disorder that spills blood directly into the tubules. Also, anticoagulation therapy, severe anticoagulation can give you massive numbers of red blood cell casts. So if you don't see a glomerular process, anticoagulation therapy should also be brought up as a differential diagnosis. Okay?
Great.
So that's the pitfall with red blood cell casts. You would think they'd be easy, but they can be extremely difficult. All right, we have two more cast types to talk about, and the discussion for these is quick, and we can probably save that for the beginning of our next session. Does that sound like a plan?
What are they?
So I have bile casts and I have neutrophil casts. And it's up to you. We can keep going or we can pause and continue with our next session.
Well, what do people say? Keep going? Just finish these two out? Keep going is what people say.
All right, excellent.
We're really into casts. Really nice
All
job
right,
so far. Yeah.
Thank you.
But we can just wrap these up maybe in 5 minutes and call it a day.
Yeah, these will be quick. So neutrophil casts, typically seen with ascending bacterial infections, although not always. All right, so here we have a neutrophil cast swimming inside of a tubule. Here's 1, 2. You can tell they're neutrophils because they look like ants. They're polymorphonuclear, so you have multiple lobes of a nucleus held on by thin strings of chromatin, and they look like little ants. It's an ant party, basically. And even from low power, the kidney looks. Yeah.
Never heard that before.
Yeah. See, look in here. It almost looks like a bunch of ants got together.
I'm waiting for Crystal to have an infographic on ants. If she's still if she's still there.
So these casts, these neutrophil casts, are typically associated with ascending bacterial infections, although not always. E. coli accounts for about 70 to 85% of them. But it's not always E. coli. Other species are oftentimes present. One thing to note is that fungal and viral infections can also give you neutrophil casts, as well as, like I've demonstrated, lots of other cast types can be admixed with lots of neutrophils. And you can also see neutrophil casts with severe glomerulonephritis as well. The other thing, and this is just sort of an anecdotal, unpublished observation that we've noticed at Arkana, is you can get neutrophil casts with certain PD-1, PD-L1 immunotherapies for treatment of malignancy as well. So the differential, even for these, is a bit broad, but typically these are caused by an ascending infection. You can also get them with hematogenous spread, and those are usually staph infections, but those typically cause microabscesses as opposed to casts. Okay, and the other interesting thing is how these are associated with two different other things I want to point out. One is you have lots of neutrophilic tubulitis. In other words, not only neutrophils in the tubules, but neutrophils also within the actual epithelium. And then you have what we call satellitosis, or rimming of neutrophils around these tubules that contain neutrophil casts. And let me show you an image here. So you have on the left, PAS stain on the left, neutrophil casts just packed inside. And then on the right here, you have neutrophilic tubulitis and neutrophilic tubular rimming. You can see, or satellitosis, where these neutrophils are wrapped all the way around the tubule, trying to find a way in.
Any particular reason why you show PAS stain for all these, or?
Yeah, because you can identify the H&Es also. You can see this on H&E too. I'll show you the H&E on the microscope, but the PAS helps to identify where the tubule begins and ends, the tubular basement membrane. So let me show you quickly what this looks like on H&E. Even from low power, these are very, very inflamed kidneys. So here's the H&E. It's a little bit, you can see the cast. Here it is. Right, you can see how
looks like
much...
an ant party going on in the entire kidney.
Exactly, exactly, exactly. And one thing, you know, it's admixed with lots of inflammation in the interstitium. You have some plasma cells. You also have some lymphocytes. But really, it's the neutrophils that grab your eye. And notice how patchy this acute pylo is, and this is classical. So you have a core where you have lots and lots of inflammation, and then over here, closer to the cortical, to the capsule, you don't have as much inflammation, so it's very patchy. Notice here, if I just showed you this, this does not look like acute pylo, but then you go next door, and it's an ant party. Okay, classical.
Someone's asking about transplant, and can these be there with rejection? Can you give an ant party in the tubule with rejection?
Usually rejection is primarily lymphocytic. Okay, so that's important to differentiate. If you have, this is a predominantly neutrophilic process. In rejection, it's predominantly a lymphocytic process. Those are the little soldiers that you talked about last time. But you can definitely get pylo in transplants. Of course, these people are immunosuppressed, and we see pylo in transplant all the time, in which case it looks more like this. But sometimes you can't really differentiate between transplant rejection versus pylo versus other things that cause interstitial nephritis. It's impossible sometimes to differentiate. Oh, and this is a nice little finding. Here's a mitotic figure. See that? Right there in the center.
Right there. Oh, nice. Yeah.
Okay.
Dr. Farouk had to leave, so that's why she's gone.
Okay.
She's on service.
No problem. So we'll finish with the last type of cast. Okay, this is on H&E. And I think immediately what you'll appreciate, there's something very, very different about these casts, okay? Even from this power, they have something's different about them. They have a different
Some
color.
endogenous staining going on.
Something's off with these casts. Notice how brown they are.
Yeah.
They're very, very brown. They even have, some of them have a little bit of a yellowish, some even have a greenish hue, which it's probably not transmitting very well. This one, for instance, has a little bit of a green hue I can see on my microscope. You probably can't appreciate that. But they have this camel hair brown look, right? Here's one that's got a little bit of inflammation around it. It's a little bit yellow, brown, green, very, very distinct color on H&E stain, okay? Now let me show you the PAS. The PAS is not as great as the H&E for this cast type, but you have some tam-horsefall protein, uromodulin, and then you have these little brown casts around it. They're kind of granular, globular, nondescript. So what in the world are these? It turns out these are bile casts. And the way we demonstrate that these are bile casts is we use a special stain. This is one of my favorite special stains. It's called Hall's stain. And the way it works, Hall's stain, is basically it uses the oxidizing reaction of what's called Fouchette reagent. And Fouchette reagent is made up of a combination of trichloroacetic acid and ferric chloride. And what it does is it converts the bilirubin in these casts into biliverdin. And biliverdin is much, much more green, much more strongly green than bilirubin. So it basically amplifies the reaction to give you a color that's olive green to emerald green on Hall stain. Can you appreciate how much more green this is?
Yeah. When you say Hall, Hall?
Correct.
Stain?
Yeah. And Fouchette reagent is a portion of the stain process. Fouchette, spelled Fouchet.
Nice.
And then you have this beautiful pink-yellow background. So the green really gets pulled out by this chemical conversion. And this is how we diagnose bile cast nephropathy. And typically these folks are jaundiced at presentation, as you might expect. They have really high total bilirubin levels that typically exceed 20 milligrams per deciliter. There's a study led by Dr. Tony Cheng in Chicago where they looked at 44 tissue samples from from jaundice patients. 41 were autopsies and 3 were biopsies. And they showed that about half of these folks will end up having bile casts in the kidney. And oftentimes they have hepatorenal syndrome, and oftentimes they have alcoholic cirrhosis, things of that nature. And of course, they have other laboratory data consistent with that. They have elevated transaminases, et cetera. But I want to show you the the slide here. So you have this camel. So this is in panel A. You have this camel hair brown appearance on H&E. On B is also H&E, and I think you can see a little bit of the green hue and lots of inflammatory reaction. On C and D, so this is fortuitous. If you see this, you're lucky. If your biopsy contains calcium oxalate crystals and there's bile, these will bind and then they look green without the Hall stain. So that's a very, very helpful feature. This is not diagnostic of bile cast nephropathy because these are just bile-stained calcium oxalate crystals, but their presence is very, very helpful. And then, of course, here's the emerald green, olive green Hall stain bilirubin that's been converted to biliverdin. And this is bile cast nephropathy.
The one thing I want to point out is that there is an ongoing debate about the significance of these. Are they pathologic, or are they just a remnant of or a secondary feature? And that's still not completely solved. So there is some debate about like what do these mean? And like you said, they often occur in an individual that has a lot of other things going on. And we actually featured this in Neph Madness 2019, and I put some of the link about these, but still very interesting.
Yeah, and typically they are associated with tubular injury, histologically at least, and the fact that they're eliciting a reaction, inflammatory reaction, to me points to their ability to directly injure the kidney. I think it has been actually experimentally shown that bile salts and bilirubin are directly toxic to the tubular epithelium. So that wraps it up, part 1. We got through the whole thing. Somebody's got some doodles on the screen too. I appreciate that. It's really nice, artistic. So anyways, these are the most common casts, and I hope that this helps you understand them better and what pathologists have to deal with. And sometimes it takes us a little bit longer to really nail them down because it requires multiple stains, special stains, immunohistochemical stains, immunofluorescence, et cetera. But these are the pitfalls and the most common intratubular casts that we see. And next time, I'd love to talk about crystalline casts and some crystalline nephropathies.
Perfect. Thank you so much. Great session. A lot of great tweets out there as well, if you want to check those out. We'll have this on the YouTube channel, hopefully in the next few hours. We will share that on Twitter once that is available. And please give us some suggestions on how to make these better. And we do appreciate your attendance and hope you learned a lot. Have a good rest of your day.
Thanks for your attention. Thank you very much.